All right. Hello. My name is Ryan Callahan. I'm a cath doc at the Children's Hospital of Philadelphia, and I'm going to give an overview of pulmonary vein stenosis. This is meant for someone who's not familiar with PVS or someone who wants to learn more as we head into this CCRC PVS module data collection. So here we go. No disclosures for this. So we're going to define and characterize what we mean by when we say PVS, specifically intraluminal PVS. Describe the different PVS patient populations and the clinical management overview. And this is just try to give you a sense of how we think about this disease and why we're collecting the certain variables that we're collecting. So very basic, what are pulmonary veins? These are the blood vessels which are bringing oxygen-rich blood from the lungs back to the heart. There's usually four, 1, 2, 3, 4, and they include the right upper, which is usually joined by the right middle, the right lower, the left upper, which is joined by the lingula, which is the small segment of the lung, kind of like the left middle, and then the left lower. The most unique variant of this would be having three vessels. The most common being that the left upper and the left lower join together before entering the left atrium, and that's called a common vein. And I'll show an example of that later on. So what is the mechanism of stenosis in PVS? Essentially, it's wall thickening. Here is a intravascular ultrasound showing the wall of a pulmonary vein. And within that is this black lumen. Here is the ultrasound probe. And actually, can you see my marker? Let's see. Here we go. How about now? Okay, so bottom right, here's the thin wall pulmonary vein, and within that is the black lumen. Here's the ultrasound probe. This is the pathology of a very thin-walled pulmonary vein. And here in the center of the screen, we see this is a patient who died of pulmonary vein stenosis. This is the heart from autopsy. This is the left lower pulmonary vein, which has narrowing. And here is that section that was cut out, showing very, very thick wall. And as a result, a narrowed lumen. This is what it looks like by path, and this is what it looks like by ultrasound. And so when the wall thickens, blood can have a hard time getting out of the lungs, and it can leak fluid into the interstitium, causing pulmonary edema or lung water, which causes patients to have increased work of breathing, potentially requiring oxygen. That can increase the pressure in the lungs, which is called pulmonary hypertension, and then stress the right heart, which can lead to right heart failure and ultimately death. Now, here we go. This is what it looks like by CT scan. So here is a left upper pulmonary vein, which has a focal narrowing right here. This is the orthogonal section to that is the very tight left upper. And here is what it looks like by angiography, where we have a catheter inside the left pulmonary vein. And you can see it's a normal size, and then it narrows down right here. And then this is the right upper, which isn't coming across very well. Let's see if I can pause this for you. There you go. You can see the arrows pointing to the area of constriction between the right upper, and then you can see the more rightward is the right middle. Okay, so this is what it looks like under pathology, and the asterisks on the left picture are showing the disease. These are myofibroblast-like cells and within a mixocollagenous matrix. And this can start in a focal area like you saw in those pictures, and then can kind of progress upstream towards the lungs in more advanced cases. What causes PVS? We're not entirely sure. It's generally a combination of factors. A lot of these patients do have a genetic abnormality or at least abnormal testing, which in itself could be contributing to the PVS, or it's more likely the issues related to that genetic syndrome that contributes to the PVS, such as trisomy 21 patients have sleep apnea, and that can contribute towards PVS. We do think that the the flow in the vein is disturbed, and this is causing increased wall shear stress. Simple logic is thinking about it as flow turbulence. And what causes that is increased flow. So if you kind of turn up the hose really fast, you're going to have more turbulence through that hose. And that can occur if there is increased flow going to the lungs more than normal or going through a particular segment. And that can happen if a patient has a hole in the heart or an extra blood vessel, such as the patent ductus seriosus, and that can send more blood flow to the lungs and through those veins. And we have demonstrated that patients, particularly with trisomy 21, who have these defects that are exposed to these defects for a longer period of time prior to surgical intervention are more likely to develop PVS. This combined with usually an anatomic vulnerable vein, such as the common vein that I mentioned, or veins that are not perfect circles as they're entering the heart. And so the surrounding anatomy is distorting the vessel or it's compressing it, or patient was born with a vessel that was innately at a unique angle that causes an angulation or a kink, or there's extra tissue inside the heart which obstructs the vein. So increased flow plus an anatomic vulnerable vein can generate PVS. But not all patients, so a lot of patients have those issues and don't develop PVS. So we need another element. We need another trigger or stimulus, as we say, and that's typically lung disease. Most commonly bronchopulmonary dysplasia, which is associated with premature lung disease, and then aspiration or food or liquids going into the lungs is a very noxious trigger. I mentioned sleep apnea already. We've demonstrated that patients who are experiencing aspiration, if they already have PVS, are more likely to not respond to therapy or die. When we diagnose PVS and look back in the chart, a lot of our patients are having aspiration or feeding intolerance of some kind that are likely leading to little microaspiration. We also see patients have infection of some kind, or there's an association between necrotizing enterocolitis, which is a unique type of infection of the gut that happens in premature infants. And so, all these things combined leads to a perfect storm, and this is when we typically see PVS occur. Now, not all pulmonary vein obstructions or things that can give turbulence or gradients causes that is, in fact, wall thickening or intraluminal PVS. There are many things that we can see, such as a anatomically distorted vein. Here we have the left lower vein that is being squished in between the heart and the aorta here. This is normal. This is not PVS. Again, in angiography now, this vein is compressed between the aorta, marked by the pigtail, and the heart mass here. We can have just odd connections of the pulmonary veins that patients were born with, or membranes inside the heart, which can cause disturbed flow, but not PVS. Here's an example of an obstructing membrane within the heart. This is called core triachiatum. Or patients can have surgery on their pulmonary veins as a result of the veins they were born with. And the area of obstruction can be at the area of the surgical manipulation and not necessarily the individual veins. And here's an example of that, where these left-sided veins have to come all the way across the heart and make this 180-degree turn. And so the veins are kind of distorted with entering a very small surgical opening. With that said, all these issues can lead to PVS or the wall thickening. But it's important to know that this is what we're talking about when we're going forward and studying these patients in this registry. Now, what type of patients develop PVS? I've alluded to a little bit, but let's go into more detail. And so I think about this as kind of 4 main types, 3, and then divided into 2 more with congenital heart disease patients. And let's go through these one by one. So this has a lot of different names. I think the most common would be congenital PVS. And this is the rarest type of PVS that we'll ever see. This is typically in a full-term baby who has a structurally normal heart, who is well initially, and then at 3 months of age develops failure to thrive and has trouble gaining weight and is not tolerating feeds. Or they can present a little bit older because they kind of limp along for a couple years, but they have poor growth and are treated for what is believed to be recurrent pneumonia, but it's really just congestion on X-ray as a result of veins becoming obstructed. And they typically present with respiratory distress and failure, really high pulmonary pressures, and sometimes heart failure. Like I said, the vein anatomy is normal, but like as in the connections of the vein to the heart are normal, but they develop that luminal narrowing from that wall thickening. It's very aggressive, and this can occur in siblings. So we only see about a case every 1 to 2 years at a busy institution. So this is pretty rare. Next, which we see frequently, is PVS associated with prematurity in lung disease. And these patients typically present at 3 to 6 months of age. They usually have early gestation, like they were born more premature, or they were born very small, small for gestational age, that's SGA, or they didn't grow very well as a fetus, so intrauterine growth restriction, or IUGR. They usually have bronchopulmonary dysplasia, but the severe variant requiring mechanical ventilation with a breathing tube in the lungs, and the severe types are mechanically ventilated at 36 weeks postmenstrual age. So if they were born at 24, 12 weeks later, they're 36 weeks of age, PMA, and if they're still ventilated at that time, that's a risk factor. They usually have a history of the necrotizing enterocolitis, as I mentioned, and a defect causing a left to right shunt or more blood flow to the lungs, such as a duct, an atrial septal defect, or a ventricular septal defect. And they usually present with worsening or not progressing, not improving as the docs think that they should, respiratory status of unclear etiology, and it's usually diagnosed by echo, which we'll see later. Now, one study showed that this occurs in about up to 5% of patients with severe BPD, with the associations that I mentioned. A very large study of 10,000 patients found the prevalence was around 1.1%. Now, a lot of the institutions in this study were not screening their babies, so it's likely this is the floor, not the ceiling. And again, we've highlighted a lot of the risk factors for developing PVS in these patients. All right, PVS associated with congenital heart disease. And so the first type of this is patients who've had an operation on their pulmonary veins, something a lot of people call secondary PVS. And so the main example is patients who are born with veins that do not connect to the left atrium, and that's called total, where all the veins don't connect, or partial, which is P, anomalous pulmonary venous connection. And so that has to undergo surgical repair. So they reestablish the connection between the left atrium and the veins. And about 15% of those after the surgery can develop some kind of pulmonary venous obstruction, which is quite a high number. Some of them do it silently, and they just lose veins without any symptoms at all, and others are quite sick with failure to thrive and respiratory failure. And the highest risk factor for patients who to develop the obstruction are the babies who are born quite sick, and the veins are already obstructed, and they have to go emergently to the operating room. If they're repaired quite young, and as a neonate or infant, which is the most common time these days, or if they have residual defects after the repair. So even right after the surgery, they still have obstruction within their pulmonary veins, and so that's an ominous sign for a potential issue in the future. Another type of vein repair is the core trichotum repair. Actually, it's not a vein repair. They're just removing the membrane inside the heart, but this diagnosis is associated with PVS, as over 10% of the patients in this study had PVS associated with their core trichotum. So you might see that diagnosis come up from time to time. And then the last type is PVS associated with congenital heart disease and a patient who has not had a previous vein repair, but they have those risk factors that we talked about. So the veins are distorted and they have increased flow through those veins. A couple examples would be, here's a, let's see if I can play this. Here's a patient with stenosis of the left upper and the left lower pulmonary veins. And if you look at this picture, there was an obstruction of flow to the right pulmonary artery, and it was sending most of the flow to the left lung, and that caused PVS. In this example, this is an example we see frequently. This is a left common pulmonary vein that is now atretic, so it's lost its connection to the heart. So this patient had the vulnerable vein with the common vein. They also had this vein being squished because they had a VSD, a ventricular septal defect, that sent extra blood flow to the lungs, and that dilates the heart. So you have extra flow going through a common vein that's squished, and that leads to atresia. So we're doing better. These are Kaplan-Meier curves showing survival outcomes that have been published most recently. The first study showed that all the patients died, and then with over time, another study showed the survival curves were improving. And this is the most recent survival curve from this institution, showing that the 5-year survival, well, this is 2 years, but I think ultimately the 5-year survival is, depending on the institution, hovering around 70 to 80%. Here's a second center who this was their initial cohort. Survival was 50%. And then more recently, a small cohort of patients, 15, all survived to this point. And then institution number 3, demonstrating an improvement in survival by changing their stenting patterns from bare metal stents to drug-eluting stent, and then that same institution showing the success they're having with a medicine called sirolimus, which I'll talk about later. So again, showing that 5-year survival to be somewhere between 75 and 80%. This is showing that restenosis is common even after therapy. But if you can stay ahead of it and you continue to provide reinterventions on the veins, they have a better chance of surviving. And this interesting graph is from an older cohort of PVS patients, but it shows in the top panel all the patients who died here and all the patients that survived. And all the marks underneath the curves are interventions such as surgeries or caths. And so you can see when they're first diagnosed, there's a fair number of interventions. But the survivors, as they kind of get older, the intervention slows down. And so, and in a lot of cases, or in some cases, the disease completely goes away and burns out after a few years. And so that's what we try to do. We try to stay ahead of this disease as best we can until the disease cools off. And so ultimately, we had a universally fatal disease, and after the application of new therapies, and we'll go over the current management of PVS, it's kind of turned more into a chronic disease with the expectation of restenosis that we treat as best we can. And this was like a typical patient that you might be collecting, someone who's had pretty aggressive PVS, but you can see over the course of 6 years, they've had numerous surgeries, numerous catheterizations, imaging studies, medical therapy, hospitalizations. And so it's a lot potentially for the older patients going back and collecting all this. Okay, so diagnosis is typically started with an echocardiogram, which gives us the first hint that there might be an issue. So we'll be collecting some of these matrix. You can tell with echo what the squeeze is of the right heart, the valve function, kind of estimation of the pressure on the right side. You can see congenital heart disease, such as the shunts that we talked about, and you can see the veins. And so if you can't see it, doesn't mean it's not there. You just might not be able to see it. And you can get a sense of how much turbulence there is in those veins by quantifying the Doppler and turning that into gradients. But we're not very good at determining the mechanism of obstruction or the vein size. And so that's for other imaging modalities. Okay, so now we're going to go into this PVS management, and this can vary from institution to institution. And this is just me trying to give you a broad overview of how these patients are managed, so you understand why we're collecting some of the things that we're collecting. Okay, so let's go through this. So we confirm PVS typically in the cath lab, and then we treat the stenosis. And we can either treat the stenosis with cath or surgery, but let's go through cath first. And so we can get a lot of information with the catheterization. We can collect exact numbers of pulmonary hypertension in the lungs, the severity of pulmonary vein stenosis by putting the catheter inside the vein and measuring the pressure. Take pictures of the pulmonary veins, as you see here, showing narrowing at the left upper, and in this instance, narrowing at the left lower. We can look at the wall of the vein itself with a tiny little ultrasound probe. This is called intravascular ultrasound. And here's the picture. So here's the probe. The black is where the blood is. And then this is the wall lumen, which should be paper thin, but it's thick because there's PVS. There's another type of imaging modality called OCT, which some institutions may also be using. All right, so now let's talk about the different interventions. And so the mainstay of therapy, the most common intervention we do in the cath lab is conventional balloon angioplasty. That is essentially when we put a balloon inside the blood vessel and we inflate the balloon, and we're essentially just stretching and or tearing the inner layers of the vein in order to increase the diameter. So a wire goes into the vein, balloon goes in, balloon goes up, balloon comes down, and then it's removed from the body. And then we take a picture. We have other types of balloons, notably a cutting balloon angioplasty. And so these are balloons that have blades or atherotomes on the balloon. They kind of come out as the balloon is inflated and it scores the inner layer of the veins. We tend to use these if the conventional balloons aren't working, like if we're going to high pressure, but they're not working. And so then we'll typically go to the cutting, or if the vein itself is like very thick, like this example here, which we're not playing, but that's okay. Essentially, the vein wall is very thick and it kind of spits out the conventional balloon. The cutting balloon is more effective at kind of staying inside that vein. And then we also use it to treat in-stent restenosis. So this is a patient who's had stents placed in the pulmonary vein and there's buildup of stuff inside the stent here. Okay, and so here we want to clean that up without overexpanding the stent, and that's done with the cutting balloons. This is the final result there. We have two types, these smaller balloons that go up to 4 millimeters, which is the Wolverine, and then we have peripheral cutting balloons up to 8 millimeters. So, but it stops at 8. So fortunately, we don't have balloons bigger than that. Okay, how about stent placement or stent angioplasty, as it's also called? I showed you a picture of some stents, and this is another type of therapy that we use. So if the balloons are ineffective, or there's a mechanism that we can't treat with the balloon, like we have to push this tissue aside or we have to make this oval circle, we'll consider a stent. Some institutions use stent as their primary therapy. So as soon as they're diagnosed with PVS, everybody gets stents. And so there are different practice patterns that you'll see around the country. We also use stents if balloons aren't working over and over again, or after we've done vein recanalization. So you might see that a vein, in fact, is atretic, where it loses its connection to the heart, and then we have to reestablish that connection using special equipment, such as a special wire called a CTO wire, and then we can put a stent in. And so it's common for us to put a stent in after vein recanalization. So that's the result there. Large veins, at least 8 millimeter diameter, there's less in-stent restenosis. And so here's a 8 millimeter stent going in, and then follow up here is now 10 millimeter stent. Keep going here. Okay. more recently, and the adults are loving this right now, there's something called a drug-coated balloon angioplasty. And so you'll start to see this more over the next few years, probably. There's only one balloon that's currently FDA approved, and that's the Boston Scientific Agent balloon. But you'll see more balloons become approved over the next few years. Essentially, there's drug on the surface of the balloon, and as it's inflated in the wall within your lesion, it impregnates the vessel with drug, which can stay in there quite a bit, sometimes up to 30 days. And that drug can try to work inside the vein to prevent restenosis. This particular balloon has paclitaxel on it, which is the most common drug, but there are also sirolimus drug-coated balloons coming out. But we don't know, there's no prospective data on the role of this for PVS, but you'll see some people using it on their patients. Okay, what about surgery? All right, I'm not going to go into too much detail because I hope to have someone else go over this stuff with you. But essentially, if the disease is mainly close to the heart, not further upstream into the lungs, those are good surgical candidates. And they essentially use various techniques to try to remove that disease and then change the geometry of the vein to make it a good circle again as it's draining into the heart. The most common is the sutureless type repair. And this is an example of that where if this is the stenosis here, they make cuts into this to open them up. And then instead of suturing them to patch them to make them bigger, they just take the membrane around the heart, the pericardium, and they suture that around that area, kind of creating a new well for the veins to drain in. So that's the sutureless. They can also just kind of, remove the vein, remove the disease, and then reimplant it. It's called osseoresection reimplantation. And then, or they can really extend really be very aggressive with removing a lot of the disease and extending things out quite laterally and then patching the veins anteriorly. And that's called the anatomic repair. I show this slide just to show you an example of a common vein, and common veins can do well with surgery, particularly when paired with drug therapy. But here's a common vein example where you have the left upper coming in and the left lower, and they come together before entering into the heart. I just want to show that example. And there's some other weird looking veins, such as these, which is also a common vein on the right side. See all these veins stop playing, come together and form one vessel before entering the heart, and same thing over here. Okay, now we're collecting all this data, and because we think, there's some patients which can do, we want to really understand why patients are doing better or worse. And here's what we know right now, but this could change as we, do more powerful analyses with much higher sample sizes over multiple centers. But based on previous literature, we know that the more veins that are involved, the worse the patient can do. The more disease within each vein, the higher the pulmonary artery pressures, the more severe the pulmonary retention, the presence of right ventricular dysfunction, if you're diagnosed less than 6 months of age, or if you're aspirating. So those are the highest risk patients. So we have survivors in all these subtypes, but these are risk factors for poor outcomes. This slide just shows that we do put thought into kind of trying to remove the triggers, the stimulus for the disease once we make the diagnosis, but I'm not going to go into that detail here. Okay, so now we are going to so we've treated them, we've made the diagnosis, we've treated as best we can in the cath lab. We're going to try to remove triggers, and now we want to stop the disease from recurring, and we want to suppress it. And so we use medical therapy for that. And there's two big groups of medical therapy. One is imatinib and bevacizumab, or Gleevec Avastin. And I will tell you that the Avastin is a drug that's used the least. But in the initial trial, Gleevec and some patients were on Avastin. And essentially, the take-home point from this is that overall the drugs were well tolerated, even though they're essentially chemotherapy, but it's kind of targeted chemotherapy. It's not big gun chemotoxic chemotherapy where the hair falls out and things of that nature, but it's more targeted. But so these complex babies tolerated the meds, and that the patients who did the best were the ones that got most of their doses. So they got at least 90% of their Gleevec doses, were more likely to not have restenosis. But it did have trouble overcoming patients with active lung disease, where they continued to have restenosis. They didn't necessarily die, but they continued to have restenosis on therapy. And this is a secondary analysis, which again showed on the vein level, the veins did better if the patient got most of their drugs. Well, I'm going to keep moving. Okay, the other drug, which is probably more commonly used across the country, is sirolimus. And there's the adults have data and pediatrics have data, which shows that when used in combination with stents, it can mitigate in-stent restenosis, and that drug-eluting stents, which have it's going to talk about the type of stents. There are different types of stents which we use in this disease. The smaller stents, up to 5 millimeter, have drug coated on the stent, which kind of seeds into the vessel when they're deployed. And similarly to the drug-coated balloons, it kind of has drug which lasts up to about 30 days, which tries to curb the inflammatory component of putting the metal against the vein, and preventing stent failure, essentially preventing in-stent restenosis. And so we know that when you have to place a small stent, it's better to place a drug-eluting stent because they do better in all types of vessels. But then the larger stents that we place are all bare metal stents. So they're just metal. They don't have any drug on them. Okay, so back to when this sirolimus was given in the gut, so systemically, it can slow or prevent in-stent restenosis. And then programs have been using it for that purpose, and for all patients with pulmonary vein stenosis, with some success. We don't quite understand. We don't have data to show. Well, you know what? I'm going to skip that part. We're just going to keep going. Okay. All right, so now we're on one of these drugs, and now we need to monitor for restenosis, since that is common, and no matter what intervention they receive, restenosis is common. So how are we going to monitor them for restenosis? Well, they'll get physical exams and clinical assessments, but what kind of testing? So there's two big groups of testing. One is echocardiogram, with or without a lungs perfusion scan, or a CT scan. And so here's an echocardiogram, and here's an example of a Doppler profile of a pulmonary vein that has no pulmonary vein stenosis, with no gradient. And as the stenosis increases, you can see that the turbulence becomes more of a rainbow pattern. You can see that picture there. And then we start to generate a gradient here, in this case, as a mean of 4. And then now a mean of 10, and we're starting to kind of lose. It's not returning to baseline. There's some loss of phasic variability. So the Doppler profile itself is changing. And again, this is the more severe case. So there's different ways to understand the severity of PVS based on echo. And then lung scan actually tells you how much flow is going into the lung or the individual vein. Because if you need to have flow to generate turbulence, to generate a gradient. And so if you have a very, very low gradient, it could mean that the stenosis isn't that bad in the setting of normal flow, or it could mean that stenosis is very severe and there's not enough flow to generate a gradient. And so here is an example of a lung scan where I think the red is the right and the blue is the left. This is anterior, this is posterior. So this is pre-catheterization. And so it was a left upper vein that was atretic and a left lower vein with severe stenosis. They underwent redilation of the left lower. And you can see that there's improvement from 11% flow to the left lung to 30% flow to the left lung. Normal being like 55, 45, depending on where the heart is. And so that's just an example of lung scan. lung skin helps with limitation. So here's a gradient of 6 in the right lower vein. We might think that's PVS, but as a matter of fact, that's the only vein that's open. So the entire left side is atretic, the right upper is atretic, and so all the flow is going through the right lower. And so that's a flow-related gradient. And then here I kind of mentioned this example where there's a gradient of 4, that's not that bad, but then you can see there's decreased flow to that upper, so there might not be enough flow to generate a high gradient. Okay, CT scan is the other way to assess pulmonary veins serially. This actually gives you pictures of the veins. I showed this picture before. Here's the left upper. This requires an IV for contrast, sometimes intubation for a breath hold. So that's that. And then also cardiac MRI is coming. Some people use cardiac MRI with different contrast agents. Ferumoxytol increases the resolution, and this is just an example of an MRI of a total veins kid, which I can't play, but just showing that we can get decent resolution in a kid as small as 4.7 kilograms. Okay, so now this is the final part of the management pathway where, okay, we diagnose restenosis by one of our imaging modalities. What do we do next? Again, we have cath and surgery. I will say most of the patients are if they have surgery, it's usually just once or not at all. And a lot of them are managed in the cath lab, but we always have that option, cath or surgery. If there's no progression, it's just kind of restenosis, then we'll stay the course and go back to surveilling. If there is progression, perhaps we'll consider adding another drug or doing something different in the cath lab or going to surgery or something like that. Okay, so who is, just to give you a sense of patients who have really nasty PVS, who is responding to therapy? So those are the patients who are home, that when they do, come in for a cath, they're not there very long. And then if they're having serial caths, the interval in between the caths is increasing over time, that they're gaining weight and they're thriving, their pressures in the right ventricle are lowering, and who is not is really the opposite. So if you see longer length of stays, more interventions, no, very little time in between the interventions, a lot of comorbidities, then those are the patients who aren't doing as well. And those are the ones we're trying to do much, much better on. We're trying to do better on everybody, but definitely those. And I think that's about it. Yes. So feel free to email me if you have any questions about this talk. And I hope you learned something and it makes your life a little bit easier when you're collecting this data, knowing that you have a little bit more knowledge. All right, but thank you for your time.